Hello, everyone. Well, good afternoon. Well, thank you guys for taking time out of your day to come out here and support Broca Strong and the amazing and important work that they're doing. We have an incredible people here to speak on this panel to inform you about the resources that they have, and if you have any questions regarding any medical attention that you or a family member may need, these people are the people you want to talk to, so you're in the right place today. All right, so first we're going to talk to, though, is Commissioner Fortuna Smuckler. She is the liaison of North Miami Beach Library Advisory Board and to the Commission of the Status of Women in Civil Service Board. So Fortuna, you can come up and tell us a little bit more about yourself. And this will be the case for a lot of people who are going to come speak. We're going to have them come up, talk about themselves, and then after everyone comes up, you'll be able to ask any questions.
Good afternoon. Before I start speaking, I do want to introduce members of the library board. Tricia Harris, the chair, and Muriel Kemp. And also, Tricia is a survivor. And she's also the chair of the Commission on Status of Women. And I want to acknowledge former Commissioner Smith, Muriel Kemp from the library board. I think I got everybody. Thank you so much for being here. They're telling me how everything is beautiful, but really, Edenia Hernandez and the library staff, they're the ones who deserve the credit for everything. Thank you. I think it was really how I got involved in this. I think it's because of my friendship with Tricia Harris. She is a 9-year survivor, and she is proud of this. This is something that she bleeds breast cancer awareness, and being a friend of hers means caring about breast cancer awareness. And I credit everything that I've brought to the city, the mammogram mobiles and events like this one, I do it for my friend Tricia. So thank you, Tricia, for being a good friend, and thank you for making sure that this happens, because this event is important to her. I also want to thank Tracy and Kate for stalking me on social media. This is how we became, this is how they're here. And the recycling shoe drive also, because they stalked me on social media, but it was a good stalking. So thank you so much to both of you for really reaching out to me and being here and for bringing awareness too. And I don't want, I'm supposed to talk about me. I don't want to talk about me because I'm just here to help and to be here for all of you, and thank you.
Next up, we have Tracy Milgram. She, of course, is why we're all here. She helped found Broca Strong in 2015. This is after fighting alone for over 10 years against her own BRCA2 genetic mutation. So Tracy underwent 2 separate benign lipectomies at 18 and 19 years old. This before being officially told that she carried BRCA2 mutation in 2004 at just 21 years old. So she dealt with a lot and wanted to have a community of women who supported each other and uplifted each other, and also felt like they had support and a place to come. And here she is. Thank you so much for doing this. I personally know people who have survived breast cancer, and for you to do something like this, I wish that they had the resources now, but now that I know, I'm so happy, and I hope more people find out about it. Give it up.
Good afternoon. Thank you everybody for coming. As they said, I'm Tracy, the founder of Broca Strong. We're here to educate. One of our biggest phrases is knowledge is power. I'm so thankful to work with Miami Cancer Institute, Baptist Cancer South Florida, with our 4 physicians today and Dr. Powell. This means the world to me, where we have the opportunity to come to different cities and different locations to educate. Knowing is half the battle. Talking about your family risk, talking about your gemline in general, just knowing what you can prevent, whether it's surgical, whether it's prevention and just getting your scans done. That's the most important thing. So I want to thank Fortuna Smuckler, Commissioner, for having and welcoming Broca Strong in your city. Really, we've been welcomed like I lived here. She's really gone way above and beyond to make medical panels happen, to make mammogram events happen. So thank you so much. And thank you to my physicians in the back from again MCI for coming out to educate the community. It's just so imperative, and you guys all know how I believe. So thank you everybody for coming. We really appreciate it.
Dr. Arles Martir, she is an MD and a medical geneticist at Miami Cancer Institute and a world-class cancer center. She's part of Baptist Health South Florida. She trained in internal medicine, genetic diagnosis, and the treatment of patients with hereditary disorders. So give it up for Dr. Arles Martir. She's gonna tell us a little bit about her background. She's both fluent in Spanish and English, so thank you for being here.
Hello, thank you for the invitation. So, yeah, I'm Dr. Martin Negron, but to short it, Martir. And I'm a geneticist. My background is internal medicine. I study medicine in Mexico, internal medicine in Puerto Rico, and general genetics in the University of Alabama, Birmingham, and a fellowship in cancer genetics at City of Hope. In genetics, we see patients usually who has been recently diagnosed with breast cancer, and this is for surgical decision planning. We also see patients who, or individuals who have a strong family history of cancer. We also see people that comes already knowing that there is a mutation in the family and they need to be tested to confirm if they carry or not the mutation. And since we have many survivors here, we also see patients that have been tested a long time ago, and now with new genes that have been associated with breast cancer, it's important to see the geneticist or genetic counselor and have a conversation and see if more genes are necessary. When somebody's recently diagnosed, they usually see the surgeon first, and you're gonna see a surgeon today. And the surgeon, in order to help with the surgical decision making, send the patient to genetics. When they come to our clinic, they will usually see a genetic counselor first, unless you have been tested before, and you then see a geneticist. Testing is ordered if it's appropriate, or in cases that we see people with family history, we may say you have a better person to test because it's closer to the affected, or are those who have, or is the individual who had the cancer in the family. Maybe many people believe that genetic testing is very difficult to get, very expensive, but it's usually covered by insurance. And in many cases, well, in the past, the test was $4,000 for 2 genes, and now we can test for many up to 91, depending on the panel, more than that, and it's $250 if they have to pay. And I said if they have to pay because there are many programs in these labs, and this is very important. It's available, it's accessible, and the payment plans, and for patients who have been recently diagnosed with breast cancer, have a current diagnosis, and a current diagnosis of breast cancer is you having being recently diagnosed, or if you are in any treatment, even the medication that you take for 5 and then other 5 years, you still consider somebody with a current diagnosis, and many labs offer testing for those patients without cost. And in part this is because the American Society of Breast Surgeons is recommended the consideration of genetic testing for anybody who has a breast cancer diagnosis. Study has demonstrated that you could have a very strong family history, and you can maybe not have a strong family history. Why? Because you don't know all the information, because the family members live in other country, and all because there are a lot of males in the family. And even though male can develop breast cancer, the risk is very low, even with a mutation. And when we talk about mutations, usually is prostate cancer, the one with the highest risk. So it can give you the idea that there is no mutation, and that has opened the door for testing to be more accessible. So this is very good news, and so that's one of the myth of people that believe that genetic testing is very expensive. It's no longer that expensive. What we recommend for individuals to have pre-testing, this is to sit with a genetic counselor to discuss, have a family tree, and then we offer testing. We explain what to expect from genetic testing and what not to expect. Carrying a genetic, so testing, let's say, positive for a mutation doesn't mean that you have cancer at that moment or that you will definitely develop those cancers. What it means is that you are in an increased risk, and there are many things that you can do to prevent. Nobody said that the decisions that some individuals have to take because they carry a mutation are easy, because they're not. But when you put this information in the balance, is prevention and early screening, and in some cases removal of organs, are the best way to make sure that you have a healthy life. When we talk about cancer predisposition, we think about BRCA1 and BRCA2. It's the same as BRCA1 and 2, but BRCA is the analysis, the name of the analysis. The gene is the BRCA1 and BRCA2, and but there are other genes. There are at least 6 genes that are associated with a high risk for breast cancer. There are other genes with a moderately increased risk. Breast is not when we think about cancer predisposition for breast cancer, if we have a family history, for those unaffected, it's not only breast cancer at early age, is how many breast cancers, also ovarian cancer and pancreatic cancer. We look at the family history, and we can offer a panel testing. We look at other cancers in the family. It's possible for an individual to have more than one mutation, and this is why a cancer panel is a good option. Also, if you carry a mutation, there's a 50% chance of passing down the mutation. When we talk about cancer predisposition, it's not only about yourself, but also your family. And this is an information that has to be shared. We have 3 possible results: positive, meaning that you have a genetic defect, you were born with a genetic defect that puts you in an increased risk; negative, meaning that you don't carry a mutation, and that is the most common because 12 to 15% of the cancers are associated with a genetic predisposition. But even if you're negative, we do risk assessment for family members in order for them to know if they need to have either genetic testing or what is the risk for breast cancer for better screening. The 3rd result is inconclusive, a variant of uncertain significance. If you have a variant of uncertain significance, I call it negative until proven otherwise, because in 90% of the cases, this is nothing. They are benign changes. In some cases, and this is something very important that we have to take into consideration, that they're comparing the data that has the diversity is not the best, because for many years this was mostly a test for the Northern European and Ashkenazi Jewish. And when they're comparing, maybe the variant that you have is something that is very common in where your family is from, is very common in your family, but we're comparing to something, to a data that is not diverse. With time, when we enrich this data, the numbers of variant of uncertain significance it's gonna be lower, and there is also other tests that we can. Now we added RNA testing that is helpful for this inconclusive, for certain inconclusive, not all of them. So I highly recommend to think about genetics and to, even if you were tested, to give us a call. We are in Miami, and we see patients telehealth. We can see any patient in Florida as long as the insurance allowed. We also serve plantation. And we are here to help, and if you have any question, I'm gonna be available, okay? It was a pleasure.
I have a question. So for people, parents, a mother or a father, when they're trying to or considering having a baby, is it important to do the genetic test? Because you spoke about mutation.
Yes, that's a great question. Yes, mutation can come from mom and dad. Even if it's breast cancer, ovarian cancer, it can come from that. We have 50% of our genetic information for mom, 50% from dad. If somebody knows that they carry a mutation in BRCA1, BRCA2, PALB2, RAD51C, RAD51D, if they carry one mutation and the partner also carry a mutation, this is associated with Fanconi anemia, which is a very aggressive condition. ATM is associated with ataxia telangiectasia. This is when you carry 2 mutations. So this is very important and is discussed in the session. So something else is if you carry a mutation and you say, I don't want to pass down the mutation, there are multiple options. Some individuals may decide, and this is a very personal decision, they may decide, I don't want to have children, or they may decide, I would like to use an egg or sperm donor. They may say, I will adopt. They can also do what is called pre-implantation genetic diagnosis. And that is, again, what I'm gonna say is not for everybody, but it's available. And this is basically embryo selection. It's creating the embryo in the lab, and when the embryo have enough cells, they will remove one cell, they will test, and they will transfer the embryos without the mutation. Obviously, they will try to look for the two if we're talking about individuals who both carry a mutation. And then know also that even though it may be very scary, know that you can pass down the mutation. These mutations, the one associated with a genetic predisposition, except for one called TP53, affect adults. And when you talk to us, we will tell you it affects children and when is the right age. If there is any mutation that affects children, we will let you know. But yes, that is available. It's not for everybody, but I encourage that when somebody carries a mutation, the partner get tested while they are in family planning.
Dr. Charles Vogel, board certified breast medical oncologist. He's an MD and he joins Baptist Health's Miami Cancer Institute. Dr. Vogel specializes in breast cancer treatment and prevention.
I'm a medical oncologist and I'm only part of a team. The management of breast cancer involves many different specialties, and usually diagnosis starts with the breast imagers, the mammographists who will diagnose breast cancer and then usually suspect it by mammography, ultrasonography, and then do a biopsy. And the patient is usually sent to a surgical oncologist, and you'll be hearing from Dr. Nocero, one of our team, in a moment. Another part of the team is the radiation oncologist. Not everybody needs radiation therapy, but if you have a lumpectomy, virtually everybody gets radiation therapy. Dr. Nocera will, I'm sure, lead right into Dr. Medina, who's a plastic surgeon, another member of our team, who is able to do reconstruction. And for this particular audience, where there is likely to be a preponderance of women who have had mastectomies, likely bilateral, Dr. Medina is a critical part of the team for BRCA carriers. Beyond that, we have nutritionists, nurse navigators, nurse practitioners, and a vast array of other individuals, all aimed at one goal, and that is to lead to the successful outcome of therapy once a cancer is diagnosed. So I'm a medical oncologist. So what do medical oncologists do? Well, I don't operate, I don't do blood. I sort of faint like, so it's not a good idea. And I'm not a radiation oncologist. Medical oncologists deal with medications. The first word that comes to mind when you think about medications is the word chemotherapy, which is the second scariest word after cancer. But chemotherapy is something that not everybody with breast cancer needs, and it's something that we would like to, in the long run, do away with. We're stuck with it for a while, but in the meantime, with early stage breast cancer, we now have some types of genetic tests, not the genetic tests that you just heard about, but other genetic tests specifically testing the tumor and the genes within the tumor. And by analyzing those genes by tests called Oncotype or MammaPrint, we're able to determine whether a patient just diagnosed with breast cancer does or does not need chemotherapy, in addition to anti-hormonal therapy. So the big advance really in early stage breast cancer over the past 10 years has been these tests, because we've been able to reduce the number of women getting chemotherapy for early stage breast cancer by 25%. So that's huge. Other advances that have occurred during my lifetime, in fact, I really ushered in the modern era of breast cancer, because I came here in '75 to start the Sylvester Cancer Center before it was the Sylvester Cancer Center. And in '75, we had radical mastectomies. We were doing them then. Dr. Nocera will tell you that we no longer do very many radical mastectomies anymore. Radiation therapy was done by cobalt therapy in 1975. No more. Now we even have proton therapy, but we don't have a radiation oncologist here to tell us about those things. So what else did medical oncologists do besides chemotherapy? I told you we're trying to move away from chemotherapy. So what replaces it? Well, for many women, the disease is under the hormonal control of your body. And so we have various types of anti-hormones that we can use. And then the newest tools in our armamentarium are targeted therapies. And I was privileged to take part in the early clinical trials of Herceptin for a specific type of breast cancer called HER2 positive breast cancer. And that revolutionized treatment for women with HER2 positive disease. So that is a target. HER2 is a gene that occurs in everybody. We all have 2 copies of the gene, one from our mom, one from our dad. But that gene does good things in the body because God puts genes in our body to do good. However, if there are too many copies of the gene, it becomes an oncogene or a cancer-causing gene. And then that's a bad gene. And Herceptin is an anti-gene therapy. So now the medical oncologist has chemotherapy, got anti-hormonal therapy. We have anti-gene therapy. We also have, for BRCA patients, another targeted therapy called, there's a substance called PARP in our body that repairs DNA damage. And if all of our treatments damage DNA, and we want the DNA damage to kill the cancer cell, well, PARP repairs the damage. So now we have PARP inhibitors. And PARP inhibitors are specifically used in BRCA carriers. So that's very important for this population. So we also now have immunotherapy. So we have chemotherapy, anti-hormonal therapy, targeted therapy, and immunotherapy. And triple negative breast cancer, which would take too long to sort of describe. Basically, breast cancer is not one disease. In 1975, for us, breast cancer was one disease. Now it's 4, has just become 5, by the way. So what are those types? There's estrogen receptor positive, good risk, estrogen receptor positive, poor risk, HER2 positive, triple negative, which is patients who do not have estrogen receptors in their tumor, progesterone receptors in their tumor, or HER2 in their tumor. Those are triple negative. That's especially important for this population because most of BRCA1 carriers, when they get breast cancer, are triple negative. And triple negative is a new bad girl of breast cancer. So, but we have therapies, and now immunotherapy is becoming more and more important in triple negative disease. So we made great strides in curing more women with early stage breast cancer, and we're probably up to the 80% range at this point in curing women with early stage breast cancer. And medical oncologists participate there by helping the surgeon, helping the radiation therapist, by giving anti-hormones, chemotherapy if necessary, immunotherapy if necessary. We can also sometimes give these treatments before surgery for women who have very large tumors and still want to preserve their breast. That's called neoadjuvant therapy. So we've made great advances in early stage breast cancer. And then probably the last thing I'm going to talk about very briefly is metastatic breast cancer. Metastatic breast cancer is breast cancer that has spread to other areas of the body, the lungs, liver, bones. It's a misnomer. Sometimes people say, well, I had breast cancer and now I have lung cancer. And usually that's not the case. Usually it's breast cancer that has spread to the lungs. Very big difference because the treatments for breast cancer and lung cancer are very different. The problem with metastatic breast cancer that as of 2022, this is still considered as incurable, but not untreatable. And for that reason, I just finished publishing a book, and that book is entitled Living with Metastatic Breast Cancer, Stories of Faith and Hope. It wasn't supposed to be named that. The second part of the title was supposed to be You Are Not a Statistic. And so it's a story of 40 patients in my practice right now who are living 10, 15, 20, 25 years with incurable metastatic breast cancer. So it's an inspirational book, and if you have metastatic breast cancer, I strongly urge that you read it. Now the question is, how do you deal with talking to a woman when they are found to have metastatic breast cancer? How do you instill hope and faith? And that's one of my jobs. I mean, it's much easier to deal with early stage breast cancer where you can say, okay, I'm going to give you chemotherapy and anti-hormones, and the likelihood is that we're going to increase your likelihood of cure by some finite percent. And cure is a nice word to be able to use. With metastatic breast cancer, you sort of have to change the tone. And the problem is that when the medical oncologist, who usually has to give this news, tells a patient that they have incurable disease but treatable, they turn off at the word incurable. And they start funeral planning and anxiety and fear. And so it's an art form in being able to change this diagnosis, instill hope, because we have so many tools in our armamentarium. One of the patients in my book it's now 12 years that she's had metastatic disease. She has had 24 different forms of therapy. 24. So just think of all of the options that are available to women with metastatic breast cancer to keep them alive, keep them functioning. She's never been in the hospital in those 24 years, ever. And so she's living a normal life. She and her husband travel extensively. So the important thing is to always continue to instill hope until the very end for those people, and that's a whole nother story and a whole nother dialogue.
Now we're going to give up for Dr. Nadia Nocera. She's an MD and is a breast surgical oncologist at Miami Cancer Institute. He kind of gave you an intro already, so you work in radiology, correct?
Me?
Yes.
I'm a breast surgical oncologist.
Okay, breast surgical oncologist. Okay, so let's give it up for her. She's going to talk more about what she does and how she helps women and men.
Hi everybody, thank you for having me here. So I'm a breast surgical oncologist. I work at MCI over in Plantation. So I work closely with Dr. Vogel and other medical oncologists, as well as the other people in the breast cancer treatment team that you would encounter. So typically I'm typically am the first person that you would meet once you were found to have a biopsy positive for breast cancer, even just a high-risk lesion. So you would be sent to me, and then I would try to help coordinate your care and send you to all the people who would be required in your treatment, such as a medical oncologist, a radiation oncologist, genetics, plastic surgery. So one of the first things I kind of want to talk about, even before all that treatment options and things like that, is the importance of screening. So as we all know, it's October's Breast Cancer Awareness Month, and we kind of bring awareness to the importance of screening this month, but we don't want to keep it just to October, all year round. It's really important to get your screening mammograms, encourage other people who are 40 and over for their screening mammograms. 1 in 8 women is diagnosed with breast cancer, and over 85% of those women who are diagnosed do not even have a strong family history or a genetic mutation. So it's really important for women to get screened. Because of all the technology that the technological advancements we've had in screening, we can catch breast cancer really early on. If the earlier breast cancer is caught, the better chance of survival you have. Stage 1 breast cancer that's diagnosed early enough, you have over 100%, you have 100% chance of survival within the first 5 years. Most women, 90 to 100%. As even stage 2 or stage 3, you have a really great survival chance as long as it's caught and you get the appropriate treatment. Even metastatic disease, as Dr. Vogel was saying, the options are incredible. So as I said, there's different types of screening options. So the best and most common is mammogram, and a lot of women will also get ultrasounds as well. Typically women who have denser breasts will get an ultrasound because that increases the sensitivity of detecting something. Also MRIs can be used as a screening tool. However, MRIs are typically used in women who are found to be at high risk, whether it be a high risk in your family history. Typically we recommend that women will get a risk assessment at least age 30 if you have a strong family history, and you can have your family history as well as your own personal history input into a risk calculator, and then find out if you're at high risk, and this is considered at least 20% chance of having breast cancer over your lifetime. So if you meet that category, as well as if you have been found to have a genetic mutation that's at high risk for breast cancer, you will be put into a high-risk screening protocol, and this includes getting screening with mammograms as well as MRIs. And typically, depending on who you see, I like to alternate mammograms with MRIs every 6 months. So this would be for a high-risk patient. So, you know, there's if patient has found to have a genetic mutation, depending on the mutation, that also changes the age at which we would start screening. For BRCA mutations, we could start screening as early as age 25 for breast cancer. And there's other genetic mutations that if you're found to have them, you would start screening at an earlier age than 40. So those are all really important things to think about. So what happens when you get a screening, then they decide that you need a biopsy, and then your biopsy is found to be cancer. So you would be referred to me, and then we would talk about your options. So depending on the size of the cancer, what kind of breast cancer you have, there's different options. We would discuss whether you would need surgery up front, or if you would need something like chemotherapy up front before surgery to help shrink the tumor. And a lot of women will come to me thinking the first thing they need is a mastectomy, and that is a lot farther from the truth than people think. There's very many options now, and most of the time we try to do breast conservation, which is lumpectomy. And there's lots of ways we can get there. And one of the tools we have is chemotherapy first before surgery to help you save your breasts. I try to offer my patients the least amount of surgery that they would need, and I think that this helps with your own recovery and self-image. However, there are cases where we do need mastectomies, depending on the size of the cancer or its biology. And in certain cases, a bilateral mastectomy would be considered. And these patients, these are usually the high-risk patients or patients with genetic mutations that I would recommend a bilateral mastectomy. And that helps to decrease the risk of breast cancer over time. And some people will tend to decide to have mastectomies or bilateral mastectomies due to their own personal preference. And that's kind of a discussion that we have. And I kind of counsel patients on, their future risk if they get mastectomies, because you can still get breast cancer after a mastectomy. So that's something really important patients should know. And if you end up getting bilateral mastectomies or one side removed, then I would send you to the plastic surgeon who would discuss reconstructive options. So it's a long journey, and you have a lot of doctors here to support you and help you through the journey and help guide you. The important thing is to ask questions and find out what's best for you and for your family, and how it's going to help you recover over time. And one little tidbit about breast cancer prevention, I know that's on a lot of people's minds. There's no specific thing that's been truly found to prevent breast cancer. However, there are some things that we suggest or have been shown to have some risk reduction in breast cancer. And one of the main things is trying to keep a healthy body weight. We know that increased body weight, increased fat within your body can contribute to breast cancer risk. Exercise helps reduce your risk. It keeps your body healthy. We had a conference the other day, and one of the Memorial Sloan Kettering physicians was talking about how much fiber can also help as well. Fiber is important in your entire nutrition, and it can help bind simple sugars. It can also bind excess estrogen within your body. So keeping a good, healthy, high fiber diet is really important. So those are kind of the main things that we like to focus on for the prevention of breast cancer. So that's my spiel, and I'll be happy to take questions later.
Do you have talk about the biggest misconception when it comes to breast cancer?
Okay, so what's the biggest misconception about breast cancer? I think a big misconception is that you will always need a mastectomy, and that's probably your only option. And also a mastectomy means that you won't get breast cancer ever again. So you don't always need a mastectomy. A lot of times we are able to save a patient's breast, and if you do have a mastectomy, there are still some breast cells left within your chest wall. So those, even though it's very small amounts, those cells can form into cancer. So we always advocate that our patients are very vigilant about their bodies even after a mastectomy, because you can actually feel if you have a recurrence, because now the breast tissue you do have is superficial and very easy to feel. So go see your doctor if you ever feel anything abnormal.
Is a plastic and reconstructive surgeon and director of microsurgery at Miami Cancer Institute at Baptist Health, South Florida. Dr. Medina specializes in complex reconstruction and microsurgery. All right, give it up. So I made a joke earlier because, he's the plastic surgeon. I was like, if you guys watch Grey's Anatomy, he's basically Dr. McSteamy. So that's who he is. That's his bio.
Thank you. Those are big shoes to fill. My part at the end of this process is very different, I think, than everyone else's. So the first and primary and most important goal is always to get you cancer free. But after that, then my job is to step in and try and make you feel whole after this process. And I think for us, there's two sort of categories of patients: our BRCA patients that are purely prophylactic, and then our active cancer patients. So with our active cancer patients, we have to be very vigilant of the other treatment things that are occurring: chemotherapy, radiation therapy, hormonal therapy, immunotherapy. So there's a lot of things that I, as a plastic surgeon, as I get you through the recovery process of feeling whole after this, don't want to interfere with the cancer care. On the purely prophylactic side of things, the ability for us to do very aesthetic breast reconstruction is really dramatically improved. So what used to be acceptable for breast reconstructions these days in many women is no longer acceptable. We've moved into nipple sparing mastectomies and able to save nipples in large breasted women and small breasted women with very good aesthetic results with the use of either implants or flaps. And so these pathways are complicated, but in the prophylactic patient, we're very, very conservative about how do we make that patient look as good as possible, because this is something that they're going through in a very elective basis. On the active cancer side of things, as Dr. Nocera pointed out, not all patients need mastectomies, and there are roles for us in some of our patients that don't require mastectomy but are undergoing lumpectomy. So very typically we'll get involved with patients that need either a large lumpectomy or patients that have a large breast, in which when they have a lumpectomy, we can hide the incisions from the breast surgeon and perform essentially what looks like a breast lift and hide the area that was removed for the breast cancer. So that has really helped, even in the lumpectomy spectrum, patients feel much better after these operations. Reconstructive surgery gets very complicated, and a lot of patients these days have a lot of options on the table. So it used to sort of be a one-size-fits-all. You had a mastectomy, they took the whole breast off, they didn't save the skin. They put in what was called a tissue expander. You'd spend months expanding that. It was a very uncomfortable process, and then you'd get this kind of flat-looking implant, or someone would try and put a flap in there that had all of these scars that were like football-shaped and very different. It looked like a breast mound, but it didn't look like a breast. Today, with our ability and with our colleagues, the breast surgeons who've gotten very sophisticated in the ability to save skin or save nipples, they really make my world much easier. So I'm able to capitalize on the changes in their ability to save skin and nipples, and then look at a patient and sort of decide what are the best avenues for you. When we talk about using your own body's tissues, patients really have to have a donor site for that tissue. So this is one of the few places in medicine where being really thin actually limits your options for things. So patients that have a little bit of a tummy, we're able to use that tummy to make a breast that can make a really nice breast. And it requires no implants, and there's a lot of patients that are worried about implants these days, and we'll talk a little bit about that. The flap procedures are great procedures, but nothing that we do is free. Unfortunately, they require removal of these tissues from the abdominal wall, so we're very focused on trying to prevent any consequences from where I take that tissue and move it to, so that I can make a good breast, but I also don't compromise where I took that tissue from. So for our patients that have a little bit of abdominal donor site and are not interested in implant-based breast reconstruction, they're very good for autologous or DIEP flaps, which is this tummy tissue with preserving all of the muscle and nerves to the abdominal wall so that we don't affect the abdominal wall function. On the other side of the spectrum of things, we have implant-based breast reconstruction. Here in South Florida, we have a lot of patients with pre-existing breast implants, so we're in an area that we have a lot of interest in implant-based breast reconstruction from our patients as well. Breast implants goes through a 10-year or 15-year cycle of concern over safety features. In the early 90s, breast implants were made out of a liquid silicone. The data on how dangerous that was for patients when they ruptured is mixed. It's very complicated. There are absolutely women that were getting sick from the silicone, but separating them out from the general population was harder than we thought it would be. But in general, those implants were bad implants. When they ruptured, they were surgical nightmares. You would have silicone leaking all through your body. Getting rid of it was a huge task. The modern implant is what's called a cohesive gel. So, and in the most latest generations of these, we have implants that you can literally cut them in half, hold them upside down, the gel doesn't come out of them. So these are soft, they feel like a liquid, but these, you're never gonna have this worry that you have free silicone leaking through your body. Those implants do very well. We call them permanent implants. They are not permanent implants. We always tell people that the the cost of an implant to you is going to be replacement. At some point, that implant will need to be replaced. How long will that be is always a question we can't answer. I have patients that have had implants in for 20 years, done great. I don't believe in programmed replacement of the implant, so because your implant is 20 years old, you come to me, should I get this exchanged? Is the breast soft? Does the imaging look okay? The implant's intact? Leave it be. We see patients that have had bad luck with an implant 5 years in, they get into a minor car accident or trip and fall, the implant ruptures, and it needs to be replaced. So that's the trade-off. Abdominal tissue, the trade-off is we have to take it from somewhere in your body. With the implants, the trade-off is that it has to be replaced. There have been a couple of major things to be aware about with implants, and one of them in particular is that implants that have rough textured shells are dangerous implants, and they're in the process of being taken off the market. Those cause a chronic inflammation of the capsule around the implant. So everyone will form a capsule, whether you have a knee replacement, whether you have a breast implant, anywhere you put something foreign in the body puts a scar tissue layer on it. These textured implants were designed because they had a nice shape in photographs. In real life, they're actually very stiff and they don't move. So I was never a big fan of the textured implants, but they were very in vogue for a while. And they can cause a lymphoma around the capsule of those implants. That lymphoma is extremely rare. The literature varies between a risk of 1 in 15,000 to a lower risk of 1 in 4,000. So we're still sorting out what the actual risk factors of those. We, in general, when we find patients with textured implants, counsel patients that these can be observed, but we do offer removal and exchange of those implants and biopsies of the capsule. That's not strictly necessary, and it's not a full FDA recommendation at this time. So if you have a textured implant, it's something that can be monitored. You're basically looking for sudden swelling of those implants, but we know those are bad actors. So we don't use any, in our practice, any textured implants. We don't use any textured tissue expanders. For our practice, I feel like most best breast reconstructions take 2 steps, no matter what you do. So there are options to try and go straight to a breast implant on the day of your breast reconstruction, or to get a flap on the day of your breast reconstruction. In general, all of those benefit from a minor touch-up procedure somewhere between 4 to 6 months after having the operation, and those are for aesthetic refinements. So our pathway kind of comes in, we meet the patient, we talk about their interest between using your own tissues, between using breast implants. Are they a candidate to save the nipple? How large is the breast? Is the breast too large to save with conventional means? When it's too big a breast to reconstruct with our implants or tummy tissue, we do operations in which we reduce the skin over the shape of that breast so that we give you the same kind of T patterns you would have with a breast reduction, and that gives a nice aesthetic result. It makes a very nice round breast. It's been a huge revolution in how we do breast reconstruction. Everyone used to get this huge scar across the breast, and that's not necessary anymore. So for our nipple sparing patients, we often have an incision that's right in the fold of the breast. Those almost disappear. For the large breasted patients, we do a T pattern, and then we do the nipple reconstruction at the top of the T. It looks like you had a breast lift or breast reduction, and it creates a very round, nice shaped breast. It doesn't create these boxy things that you'll see on the internet. You can see some horror stories on the internet. And then for most of my practice, I do 2-stage implant-based breast reconstruction. So I usually place a tissue expander and I follow that with an exchange to an implant. The reason for that being that the tissue expander buys me time. It allows that skin to recover after a mastectomy. It allows me to make sure the nipple's okay, the skin's okay. And I know that most patients benefit from a second stage for cosmetic goals. So I'm not gaining necessarily any ground by going straight to a breast implant that day. On those operations have a slightly higher risk because you're creating a fixed volume inside the space, and the breast surgeons have just cut all the blood vessels and circulation to that skin. So we want to tread lightly on that skin for a couple weeks until it's really recovered its blood supply. On those second stage operations, another thing that has made a big difference in the aesthetic outcomes of breast reconstruction is called fat grafting. So we will do liposuction of the tummy, of the hips, and we take that fat and we're able to layer it around the implant or layer it around the flap that we placed. With implants in general, that allows us to use a smaller implant, and it allows us to bring more of your tissue to the site without having to make a bigger implant, without having to use a more sophisticated flap procedure, but you get a very nice, soft, natural looking breast. So for breast reconstruction, there's a number of pathways that are very, just like all of breast cancer care these days, is very individualized to the patient's body, patient's medical disease, patient's risk for needing adjuvant therapies, meaning the chemotherapy or radiation therapy. And then in our prophylactic patients, the next kind of evolution that we're working on, and we're going to start adding this to our cancer patients, but we're starting with the prophylactic patients, is sensation. So the other thing that mastectomies take away the sensation of the breast or your skin and the nipple. This has been sort of something that we've accepted as just being part of the operation, and it's unfixable. There have been some groups around the country that have started looking at trying to preserve some of these nerves as long as they can and adding a short cadaver nerve graft to the end of that to try and bring sensation back to the breast and the nipple. There are a couple of groups that now have 4 or 5 year data coming out about this that is very interesting, and so in talking to some of my colleagues around the country, that's sort of the next evolution now. We're trying with our BRCA patients and our prophylactic patients, and we've done a few of these cases now to start adding nerve preservation and nerve reconstruction to see if, the final goal is we can preserve the skin, the nipple, and the sensation so someone really truly feels whole after the procedure.
I have a family member 2 years ago that had breast cancer, but thank God they caught it early. So she elected to have both breasts removed, where we had to take her, I think, certain times for the doctor to more or less inflate.
That's right.
So do they still do that procedure?
So
where you
that's-
need to go and
That's the tissue expander procedure. I use those a fair amount. We don't do as many fills as what used to happen. So what used to happen is people would put these in with no liquid in them, and then it would take months to get it filled. And the mastectomies changed too, because the mastectomies weren't saving as much skin as they do now. So my reason to use a tissue expander nowadays is not so much that I need to expand the skin, is that I want the skin to recover from the mastectomy. So I'll fill that tissue expander up, let's say halfway, make sure the skin looks happy with it, and usually by the end of the first month, everything's filled, and we start filling on the second week after surgery if the skin looks healthy. So my patients usually get somewhere between 2 or 3 fills, depending on what they're interested in for size. Now, we do have some patients that end up wanting to be a little bit bigger and they get a little bit more fills. We have some patients that with that 50% fill, they're happy with the breast size, the skin kind of accommodates to everything, and we don't fill very much at all.
but with the breast fill, are you able to save the nipple? Because
Yes.
they're not able to
It
save
depends on the case, but the indications these days to be able to save nipples have gotten more and more loose. For a long time, we thought of the nipple as being a risk as a cancer generating organ. And now we've basically come to an era where if the tumor is 2 centimeters or smaller and it's 2 centimeters or greater away from the nipple, you can save the nipple, and we'll send a little biopsy from the back of the nipple. And that patient can get all of the options usually. They could get a flap, they could get an expander, or they can get an implant. And it depends on the size of the breast, the shape of the breast, and the aesthetic goals.
When you say flap, what do you mean by that?
These transfers of the tissue, usually from the tummy. The tummy is the best site, and that's where we
Okay.
basically will actually remove this tissue completely from the body,
Okay.
cut its blood vessel, bring it up to the chest, and under a microscope, we sew the blood vessels back together. So it's actually a transplant operation, but it's
Okay.
your tissue to your body.
Okay, thank you.
My pleasure.
Last but not least is Dr. Michelle Powell. She is a family medicine doctor in Miami, Florida, and is affiliated with Jackson Health System, Miami. And she received her medical degree from Nova Southeastern University College. Okay, great.
Thank you so much.
Can I interrupt?
Oh, sure.
1 year ago, she came to speak here while she was in treatment. Now she is a survivor.
Thank you, Commissioner. Wow, it's been a year, and so I wanna, first of all the survivors in the house, could you just stand, please? However long you've been a survivor, just stand up. God bless you. God bless you.
God bless us.
God bless us. Yes. And I also want to send a shout out to the team. One of the things I found out during the process of going through breast cancer, and I'll just give you a little background. I'm a family physician. I've been a family physician for over 25 years. And I was religious. As a family physician, we're really big on the preventative stuff, you know? And I'm one of those doctors, if I don't walk the talk, I don't talk. So every year I did my mammogram religiously. And so I did my mammogram September of 2020. And then by November, December, I started feeling a lump in my breast. And I've always had lumpy, bumpy breasts. You know, those patients, they got the lumpy, oh, whatever. It must be my cyst, right? So the lumpy bumpies weren't getting any smaller, they were getting bigger. So by February, I was like, oh boy, let me check this out. And I did an ultrasound and had a biopsy done. And on February 28th, it was found to be positive for breast cancer stage 2-3. And I wasn't surprised. My fiance, my best friend was crying in the parking lot, and they're like, oh my God. And I was like, okay, what are we gonna do? But the thing that I wanna really address is that it's a team. And that's one of the things I found out through the process. Because I'm telling you, February 28th, Dr. Charles over at North Shore, he did my biopsy. By March 3rd, I had my port blood in, and by a week later, Dr. Varkey had me on chemotherapy, and every 3 weeks I was getting IV for 8 hours. And unfortunately, we were still in COVID, so even though my mom, my sister, my cousin, my brother, everybody wanted to go sit with me in chemo, I was by myself. That's okay, I was doing my charts. I was doing my charts with my port, my IV going, and I was there for 8 hours. And then the week after, I was laid out and I had to decide, am I gonna sit in the chair or I'm gonna sit in the couch? We're gonna go to the chair, the couch. Anybody remember this? So you decide, you have to make decisions. Are we going to, what are we gonna do? Lay in the bed all day or are we gonna sit in the chair? And then my girlfriend, who said she was gonna stay with me for 2 weeks, couldn't figure out what to feed me. Because chemo, by the way, this is in my book, Things They Don't Tell You About Chemo. After the chemo, all the taste buds are gone. And everything in my body tastes like pepper. I'd be like, it's cauliflower. How could it taste like pepper? It's pepper, it's horrible. And everything changed. I couldn't taste anything. And for me, they lied. They said I'd have a bikini body by June, and because I was gonna lose so much weight. Untrue, didn't happen. And you have to realize certain things are different for everyone. But I wanna go back to the team. So between my mom and my girlfriend, they had to figure out what to feed me. And the first week I couldn't eat. And then the next 2 weeks, I was back to myself. I thought I was back to myself, and I went to work, and I worked my 8-hour days, and then you go down again. And it's up and down and up and down. And I did that all the way until July, when I completed the first round of my chemo, and August 22nd, I did my double mastectomy. After the double mastectomy, they give the drains, and then I was like, oh man. And then they tell me, okay, I'm good to go. And they said, radiation. What the? Does this process end? That's what they don't tell you. That's another thing they don't tell you. It's a process. There's no destination on this trip, by the way. It's a journey. It's a plane you get on, and it's not landing. And I think those are the things they don't tell you, and I want people to understand it's a journey. So strap in, get comfortable, and the journey will change as things go on. And so then I had radiation for 25 cycles, all the way to December. Then I'm like, now I get my boobies, now I get my twins. And my surgeon said no. Conservative, just like I said, make sure everything was settled. And I did get my reconstructive surgery till April. And the other thing they don't tell you about chemo, those expanders, I call them Tupperware. Because if you ever felt the Tupperware, there is no moving those Tupperwares. You put that lid on and you do not drop it on the floor, and unless you throw it in the microwave, it stays the same shape. And it feels like Tupperware when you lay on them, by the way. So then we went for the reconstructive surgery. Another things they don't tell you. My right breast had the cancer, and they had to remove lymph nodes. But I opted to also remove the left because I wasn't doing this again. I'm telling you straight, we're not doing this twice, even though the possibility still exists. After reconstructive surgery, they don't look the same. They're not twins. Highly disappointing. They're not twins. They're different. One side is like Jell-O, and the other side thinks about moving like Jell-O. And it's harder. And it has to take its time back to the journey, not a destination. You have to give yourself time. And it's easier said than done, but, and as a doctor who used to counsel people all the time, oh, you have cancer treatment, and we're gonna do this, and we're gonna do that, and all are wonderful professionals who speak to people, but when you are a person going through treatment, there's some things they don't tell you, and I'm gonna tell you. It takes time. And you must be patient with yourself. But the team is so amazing. If you have a brother, a sister, a cousin, an aunt, a friend, honor them. When you're going through it, sometimes you don't even think about all the people who are your team, who's holding you up and supporting you. But I had my mother, and I had my girlfriend, and I had my staff, and I got letters poured in, and you have a team. And if you know anybody who's going through it, just a text message is so invaluable. How are you doing today? You okay? I'm praying for you. Take the time to be a team player for that person. It's so invaluable. But I really want you to know it's a journey. It's a continuous journey that you will be on. And it's okay to know that you're not going to land. So sit back, relax, and understand the journey. And one thing I want you to do for the team players as well as the survivors and those going through the process, let go of who you were. Let it go. Let it go, let it go, let it go. And I say this, any survivors out there understands what I'm saying. I was an athlete. I was working out every day. I knew what I liked to eat. I knew what I didn't like to eat. I knew how much sleep I needed. I knew it as I'm tired. When you go through this process, your appetite changes. Half the time you don't know what you like to eat. Sometimes you know what you like to eat, sometimes you don't. You lose muscle mass. It's significant muscle mass, and it's imperative that you get into a exercise program as soon as possible to activate and strengthen the loss of muscle. Imperative. They don't tell you that. But as soon as you can start activating and strengthening your muscle and return some flexibility, it's imperative. That journey will be smoother when you don't have the aches and pains in your legs because you've lost so much tone, or your arms because of the range of motion you lost. Right after surgery, I couldn't do this. I couldn't do this. And then I did this, and I did this. The whole process, I never was upset. I'm just that person, just a thing. Everybody gets, my grandma said, the Lord have mercy. That means that everybody knee shall bend for something. And I figured, well, this is mine. And I went through the process because you just go through it. But my first tears came when I couldn't zip up my shirt. I could not reach behind my back and zip up my back because the strength wasn't there. I had lost my range of motion. And you'll find on the journey things that you thought you could do or did do, you no longer can. And it's okay to mourn. It's okay to mourn. I used to bend down and pick things up like this. Now I go down, don't stay too long, because I'm going to need this to get me back up. And I was talking to the commissioner, and she said, okay, girl, that is aging. Stop trying to blame it on chemo. And I'm happy to say that it's okay now that it's a journey, and I will accept I need a little leverage. And so I'm saying to all the survivors and the team members, continue to support people even after the surgery, even after the chemo, because they're working on accepting the new self. What the new boobies do and don't do, what the legs used to do, what the mouth can taste and what it can't taste, what the hands can do or not do. Continue the support. Continue understanding it's a journey and accepting the new you, because the new you is still amazingly beautiful, amazingly wonderful, and is here for a reason. Thank you.
Breakdown, and you couldn't zip up your shirt. How did you get that spunk and that happiness again? How did you find that?
You know, it lasted for a little while. And it's the simplest thing. It's like, all of a sudden, it's like, I can't zip up. And I sat in it. And that's what with mourning, this is what I teach people with mourning. It's okay to mourn. First of all, I acknowledge it's okay to be sad. Whether it's cancer or a heart attack or a stroke, it's okay to have a mourning period. And so I gave myself permission to mourn. It's okay to mourn. And then I said to myself, as I always tell my patients, pick a date. Okay, you got 48 hours of this. You got 30 days of this. And then I'm going to start planning for the new me. And so I said, what can I do to improve the fact that I can't zip up? And I started creating a plan. Okay, this is going to be my plan. I'm going to start physical therapy. I'm going to do occupational therapy. I'm going to, every day when I take a shower, when I'm going to take the shower, in the bath and out the bath, I'm going to start improving range of motion, working that range of motion. So you sit in the morning, you plan your end date for your morning, and then you start working a plan for whatever it is you're trying to achieve and accomplish. I'm a big believer in working goals and plans. And so, but you first have to give yourself permission to mourn. Yes.
Oh, yes, my question is, with my family member, she ended up asking me, is there any type of support group that she could join, because she was so strong throughout this thing, and it seems that one day it literally just hit her out of the blue.
Yeah.
So,
My
as
number,
much as
yeah.
we try to understand, but we weren't mourning ourselves,
Yes,
because
you were.
we were one of the caregivers, and so to watch her go through this, and then, so we had to find some type of support group that she could join that would be able to understand exactly what she was going through in that place.
I think that's amazing that you brought that up. The team mourns too. And for my family, sometimes they wouldn't cry in front of me. And one day my fiance just broke down in front of me because the team mourns too. They're sad too. And when you're in it, you sometimes don't have to even see that they're in mourning. Day one, from my diagnosis, I called up my therapist. Deet, deet, deet. I'm gonna need you. And I made my appointment from day one. And once a month, I saw a therapist throughout the whole process. You have to know what's too much. And you have to know when you need help. And there's no shame in needing help. Support groups are in Aventura. Every single hospital who has a breast cancer department has a support group. But for individual therapy, which I highly recommend to everybody, First, give permission. Don't be ashamed. And in many communities, there's shame in having to see a therapist. Eradicate that shame. There is no shame in getting therapy to help you through going through mourning, to help you go through an illness, to let go of things that you used to do and now you cannot do. So for your family, individual counseling, as well as seek out all the cancer support groups that exist in every single hospital that I know of, from Aventura to Jackson to Baptist to Mercy to Holy Cross. They all have a support group, and you can call them and contact them. Yes. So throughout my whole process, starting in chemo from the second week, I was using Dr. Seebe's method, herbal medications. Every day I took the nasty coffee. It was, it's an herbal supplement. And I was on herbal supplements throughout the process. And you have to be careful with many of the antioxidants when you're on chemo, so because they can interfere. But we were using herbal supplements, and I did, and I continue. Again, as I said, one of the things that happened in my body was my whole GI system did a loop. I didn't have nausea and vomiting. I had severe constipation, which resulted in me feeling nauseated. And it was only the herbal supplement that really helped me. None of the traditional medications could help me with that. So yes, I did, and I do believe in, I believe in what works. And it's a very individual thing. And there's so many alternative ways of treating conditions, but nothing surpasses some of the things that you just have to do. If you have a mass in your body, it has to go. I mean, especially with the cancer. And how it goes and how you treat it will be a design that you create with your oncologist. And one of the things I want to say to people who are going through cancer, have gone through it, and who are family members, you don't have to date the first person you go out with. Okay? If you don't gel with that person, it's okay to seek out someone else. The first radiation oncologist I was referred to, we didn't gel. He refused to listen to my question. I asked a question, he said, excuse me, I have a question. I'm not finished my list. And I said, okay. You don't have to take the first one. So it's okay to say, you know, I may have to shop around a little bit until you're comfortable, but don't shop too long. We gotta get the treatment going, right? But it's okay to say, and it's okay to ask questions. Why am I doing this? Why do we have to do this? I was so happy the surgeon said that a lot of people want to move on. I was that girl. I was like, I got my diagnosis. I'm like, let's go, take them off. And they had to roll me back. No, you're going to go through chemo, then we're going to do surgery, and then we're going to do radiation. I was like, oh my gosh, this sounds like you want to take all year. And she said, yeah. Darn it. You know? And that's when I realized it's a journey. It's a journey. And you just sit in it. Any questions? Thank you so much.
Good afternoon. I'm Adenia Hernandez, the library director here for the city of North Miami Beach. And I just want to express my gratitude to all the sponsors that supported this event today. I want to encourage you to go by the tables. Our library advisory board has a table with some free items. Our teens made some pins, and we also have an in honor of ribbon. So if you have someone that has survived or has passed on because of it, we encourage you to go and write their name on one of the ribbons, and we will be putting them up for display. We also have here Holistically Fabulous. They're in the back if you would stop by. And we have Veronica Hibbert. She's from a clinical research center here in South Florida, and she has some great information at her table. The NMB Library Friends of the library, they are helping us so that we can support BRCA Strong. And they have some tickets for sale for a raffle that we're giving away. It's a small display from Edible Arrangements, and also from Nothing But Cakes, who also helped sponsor us. And we have the Alex Olio from the Loyalty Insurance Group that is also here. They have a great service for research on breast cancer and when you're going through the process, and they're here to support us. We also want to invite you to come back on Friday the 28th at 7 to 9 p.m. We're going to have an art exhibit here all on breast cancer, and we're gonna have a foundation, another foundation that's going to also be here. And thank you so much for the support of the community.
Hi again. So I decided that this year I wanted to do a Survivor of the 2022, Survivor 20 of the Year presentation. And this year I want to, my friend Trisha Harris, please come up. You have to. And the reason I picked her first, it's not because of all the great things that she's done to bring awareness to breast cancer. It's because next year, when it's her 10th anniversary of surviving breast cancer, she's gonna be partying somewhere. So I needed to make sure that she received this year. And thank you for teaching me breast cancer awareness. I own pink clothes now because of her. Pink is not my favorite color. Red is my favorite.
It is not my favorite color either.
Red is my favorite color. Pink sneakers, pink socks, pink hair. So to Trisha Harris, we present this to you in recognition of the bravery and your advocacy as survivor of breast cancer.
Thank you very much. Yes, it is. Very beautiful. She's gonna make me cry today.
That's my plan.
She's gonna make me cry today. All I can say is thank you very much. It was definitely a journey. I had numerous friends help me out. They were there. I didn't make any plans for myself. I had rides back and forth, both men and women, taking me, sitting with me. Of course, mine was prior to COVID, so I was able to have people with me. It was definitely a journey. I have saved many people from going through what I had to go through, catching it much earlier than mine was. Even though mine was only in the body for 2.5 months. I had hers too, triple negative. And I can say that all of my friends that supported me got me through it. And while I was going through chemo, I was helping 3 other people that had other issues. And they were very distraught and very upset. And with me, I said that I was given this because I'm not afraid to talk. I'm not afraid to let everybody know what I went through. I publicized it, I let people know. And I tried to change the world and tell people, this can be beat. You gotta fight. And at my job, there were a lot of people that came in and they would see me, and when I told them I had breast cancer because I had no hair, they looked at me and thought I was going to die. You could see death in their face. And I said, I will be here next year. Hair or no hair, I will be here next year. There are still people, I have been working at my job for around 35 years. And there are still people that come into my job right now, just come to my window and they say, you're still here. I said, yes, I am. It's beatable. Does everyone beat it? No. There are people that pass away. And it's really, really, really hard. But it is beatable if we catch it early. We all like to go out and get our nails done and our hair done. That mammogram is more important than your hair or your fingernails. Your health is the most. You've got to do the testing to make sure that you're okay. Then go get your nails done and look beautiful. Thank you very much, Fortuna. I really appreciate this.
So we want to call Dr. Miguel Medina up. Thank you. Thank you for being here. Thank you for your presentation. Dr. Arelis Martinegro.
Don't you stay so we can have all of
No, yes, will this hold the weight of all of us? I just want to.
I think so, yes.
We'll find out. We'll find out today.
Today is the test.
Dr. Nadia Lucero Zacaria. Dr. Michelle Powell. And Dr. Charles Wogay. Thank you all for being part of this presentation. Thank you for being here. Thank you for teaching so many people the importance of breast cancer awareness.
Good, doctor. Okay, good.